Okay, I'd like to welcome everyone to tonight's SAM webinar. It's been a couple of weeks since the last one, so it's great to see so many people having signed up tonight. I believe we've got quite a few attendees from 10 different countries, so welcome to everyone. We've got quite a few good speakers, 2 great lectures tonight and 5 great abstracts. I'll show you the agenda. Can we move to the next slide? Oh. Just go back to the agenda. So this is the agenda for tonight. We've got Chris Turner doing the first lecture and Peter Ng doing the second lecture with 5 great abstracts in between. During the different lectures, can you please put your questions in the question box at the bottom? Put as many questions as you want, and after each of the lectures and speakers, we will ask a few of the questions. They'll be able to answer as well on the question and answer site. If you've got any other chat you want to do, please do this in the chat box. Please tell us where you're from, etc. We're just going to ask a few quick questions. So if you bring up the first question, please. So the first question is, what's your current role? If you'd like to choose your options, a few seconds for that. And just see the results. Okay, mostly consultants. And we'll move on to the next question, please. The next question is, which specialty are you from? Move on to the results of that now. Okay, and a lot of people from acute medicine, but there is some people from other specialties, and it's nice for you to come along. Thank you. We'll just move on to the next one. And the next question is, please rate your current understanding of civility saves lives, which is our first lecture. Just move on to that. I'm quite low at the moment, so hopefully that'll be more at the end. Let's move on to the next question. And please rate your understanding of the second lecture. And for people who don't know what that means, I believe it means first do no harm. And move on to see. And hopefully that will raise towards the end of the talks. So we'll move on then. So we'll move on to our first speaker. First speaker is Chris Turner. Chris Turner works at the University Hospital of Coventry and Warwickshire. Thank you, Chris, for coming to speak for us tonight. And we'll hand it over to Chris, please.
Hi, it's lovely to be here. Just let me make sure that I have got control of the keyboard. And looks like I have. Excellent. Thank you for the invitation. It's lovely to be here, lovely to be chatting. It was 2 AM when the paediatric alert bleep went out. The paediatric registrar and the intensive care registrar arrived in resus at the same time as an acutely short of breath 4-year-old girl. The peds reg examined the child, and the intensive care reg spoke with the mum as the nurses got the monitoring on. Once the 2 doctors were done, they came together at the end of the bed and they had a conversation. It was one of those conversations where you're talking about a sick patient where you have differing opinions because the paediatric reg wanted to go with maximal medical therapy and the intensive care reg was actually much more into intubating and ventilating this little girl right here, right now. And the conversation was passionate. In fact, voices got raised and they were really asserting themselves with each other. In the end, the will of the paediatric reg prevailed and they decided to go with maximal medical therapy. The intensive care reg left, going back to the unit. He wasn't in a huff or anything. He was just simply going back and he said he'd be back later on. the peds reg started trying to get IV access, and the nurses said, "What drugs do you want us to give next?" And he said, "Aminophylline." They talked together for a few moments, and then they came back and said, "How do you make it up?" Because this was a DGH, and at night there were no specific pediatric nurses there, and they knew you made it up differently for kids. His response was, "You're going to need to go and look this up." So they did. They went away, they looked it up, they made it up. And then they came back, and that probably took them about 5 minutes. And when they came back, they said to the pediatric reg, "What rate do you want this to go at?" And the pediatric reg was still trying to get IV access. They said, "Excuse me, what rate do you want this to go at?" And his response was, "For God's sake, can't you see that I'm busy? Just give me a minute." And they did what we would all do. They took a step back and they waited. And miraculously, he actually did then go on to get IV access. So they secured the cannula, they connected the octopus, and he wrote up the medications. And the medication was delivered through the the bag of aminophylline, through the pump, down through the tubing, into the little girl's arm. And over the next 25 to 30 minutes, we delivered 15 to 20 hours worth of aminophylline, which, as you know, is a very toxic drug. So what happened? What happened next? Well, the first thing was that it was recognized that this had happened, that this had been a significant overdose. The intensive care doctor came back, the intensive care consultant came in, the pediatric consultant came in, and the emergency medicine team who'd been dealing with the trauma also came in. There was a discussion amongst the senior people, and they made a really ballsy decision. They decided to go with watchful waiting. And the reason they decided to go with that was because they felt that she was becoming so unstable that to try to do an RSI ran the risk of having complete cardiovascular collapse. So what happened next was that her heart rate went up, and I think it peaked about 240, and she started vomiting. And they decided to still hang fire. And over the next 3 to 4 hours, her heart rate came down, she stopped vomiting, and eventually she was well enough to go back to the ward, and she did fine. So what else happened? Well, there was, of course, a datix, and there was then, of course, an investigation. And the investigation found this. The investigation found that the nurses hadn't been competent, that the nurses needed to go on retraining, and that the nurses weren't to be allowed to give any drugs until such times as they had proven themselves to be competent. And I think we missed the point. I think we missed the point. I think we missed the chance to be better. And I think that if this happened again, the same circumstances, we'd likely get the same result. So healthcare is a team business. We deliver it in complicated and sometimes complex environments, and we do it with varying outcomes. And for the last 10 years, as well as being an emergency medicine consultant, I've been a governance lead. I've been investigating and trying to understand situations like this one. And if 10 years ago you'd come to me and you said, "Chris, what do you think the answer is?" I'd have been completely clear. I would have said to you that the answer is process. If only everybody did what they need to do, or what they should do. And that's fine until you start to investigate these situations and you discover that the people who are involved in errors, some of which have catastrophic consequences, the people who are involved in errors are frequently good, diligent, hard-working professionals, the sorts of people that are really knowledgeable, that you would want to look after you and yours. And gradually I came to realize that I must be missing something. And what I think I was missing was this, that process, as it's written down, is work as imagined. It's what people who don't do the job think that we do when we're doing it. But practice happens between you and me, and practice happens within an environment. And I simply wasn't respecting the complexity of that. So now if somebody comes to me and they say, what do you think the answer is, and what do you think the problem is? But what do you think the answer is? I still think that process is important, but something else is more important, and that's people and how we treat each other. And I'm really sorry, I seem to not be having control of my slides, which are not changing when I ask them to. What I would say to you is that the evidence bears us out on this. The evidence bears us out on, I'm really sorry, a bunch of my slides have disappeared, so forgive me, I just threw myself completely. The evidence is going to bear us out on this. But it'd be easy to say that I was just standing here talking about the impact of behaviour on problems and why we need to behave in a certain way in order for us to avoid errors. But that's not why we go to work. We don't go to work to avoid error. What we do is we go to work to do the absolute best job that we can do. And what I'd say to you is that what I'm talking about tonight is how we create environments where we have the best chance to have the best outcomes for everybody. Now, I've already mentioned that we work in teams, and there's lots of different ways of looking at how to get teams to perform at their peak. One way is to look at how we get individuals to perform at their peak. And you can look at the physiology of this. We can look at sleep, we can look at hydration, we can look at eating, because we know that you can start to measure the drop-off in cognitive performance at 2% dehydration. By the time we get to 10% dehydrated, we have a 20% drop-off in many cognitive functions. Now, that's not that surprising, because when you're 10% dehydrated, you're probably favouring your heart and your kidneys rather than your brain at that point. We know that if you stay up all night, that your risk-taking profile changes, and that if you stay up all night, it's the equivalent of having a few pints of beer in terms of the sorts of decisions you're making. And when we're tired, we don't make such good decisions. And pretty much everybody knows somebody who, when they are hungry, when they've not eaten for a long time, perhaps aren't the best versions of themselves. But that's just one way of looking at it. That's looking at the individuals and what helps people physiologically to be at their peak. There are many other ways of looking at it. And possibly one of the best ways of looking at this is to look at the large data sets that we have from within the NHS. And nobody looks at this stuff better than Michael West. What Michael West does, he's a professor from Lancaster. If you've not come across him, brilliant lectures, you can look them up on YouTube. What Michael West does is he looks at the large data set from the NHS staff survey and he correlates it with performance of teams and organizations. And this is the biggest healthcare survey in the world, so it's really powerful big data. And he can tell you lots of things. He can tell you things like, for example, the maximum number of people you should really have in a team is 8. He can tell you that teams which go away and have away days at least a couple of times a year perform much better than teams that don't have away days. And if your team hasn't had an away day in a long time, that's probably to your detriment. But the one thing that I'd really like to talk about for just a minute or two at the moment is about what sort of team that you're in. Because it turns out that 98% of us in the NHS believe that we are in a team, that we work in a team, but that only 40% of us are in real teams. The rest are in pseudo teams. And what's the difference between a real team and a pseudo team? Well, a real team can tell you what it is that we're trying to achieve here today, this week, this year. A pseudo team can't. A real team performs at greater than the sum of its parts. It's symbiotic. A pseudo team isn't. And what Michael West can show is that if we could move the percentage of people who are in real teams from 40% to 65%, we would save 5,000 lives a year in England and Wales. Now, when you think about that, that seems really weird. How could only 40% of us be in real teams? It's weird until you start to think about the people that we work with and what we're measured on. So I work in UHCW, it's in Coventry, it's a tertiary referral trauma centre, and we're a busy old department. I work with 260 to 280 people, and I can genuinely say that I really like them all. I know that as a consultant you get a different version of people than perhaps everybody else gets, but take as you find, and I really like the guys that I work with. And I am measured by my colleagues, and I measure them by our ability to provide the highest quality, safest care that we can manage in the context of a highly pressurized environment. And that's how I measure myself, that's how others measure me, of my colleagues. But I work alongside people who are hung, drawn, and quartered on something different, and that is their ability to deliver the 4-hour target. And for me, I think that there was a time, probably 12, 14 years ago, when the 4-hour target and good patient care aligned really well. But what's happened over the last decade or so is that the 4-hour target and good patient care have started to move apart, so that we get to the stage where we can hit the 4-hour target, but we completely miss the point of what most of us would see as good care. And that's not surprising when some people are being hung, drawn, and quartered based solely on their ability to hit that 4-hour target. And what happens when you get that divergence, is that people start to stop understanding each other. They start to feel hostile towards each other. They sometimes start to chuck crap at each other. And within the NHS in England, we have the best stroke worst example of this, and that's mid-staffs. I worked in mid-staff, so I was acutely aware of this. And at that time, the executive team were measured on one thing: finance. They were hung, drawn, quartered, and they lost their jobs based on finance. And the clinicians, the nurses and doctors, were still trying to provide the best quality care that they could. And it's easy to see how those two split apart, and how we then ended up in a situation where the guys who were in the executive suite thought that we, the clinicians, were just being awkward, and we, the clinicians, thought that they were bastards. And frankly, we probably both thought that each other were bastards, and we treated each other poorly, and we didn't talk. And because we didn't talk, we didn't understand. And the end result was that patients suffered, the organisation suffered, and eventually the organisation got dissolved. Staff suffered as well. So the sort of take home from this is that we could probably have avoided an awful lot of the stuff that went on there if we'd actually talked to each other, if we'd understood that these guys who were talking about finance, be it finance for our target, it doesn't matter what it is, these guys are talking about what seems like the right thing to them, and that our responsibility as clinicians was to help them to understand why the clinical side of things was equally important. And I don't think we tried as well as we could have done. There we go. Anyway, that's the Michael West stuff. But what I'd say about that is that we all know that correlation is not causation. It's quite difficult to do studies on this kind of stuff. And there weren't really any good studies on team performance until there were some Amir Erez started his studies about, I say Amir's about 2015, and Riskin and Erez, when they did their first study, what they did was they did some simulation work, and they took teams of people who were matched for post-nominals. They were matched for their ability to perform, supposedly, and they put them through pediatric peri-arrest simulations, and they were pediatricians, nurses and doctors. They put these guys through these arrest or peri-arrest simulations, and they were quite a useful thing to measure people on, because you can measure things like time to diagnosis, you can measure accuracy of diagnosis, you can measure time to decision to do first life-saving intervention and ability to do that intervention. And what they found, what Riskin and Erez found, was that we grade in a curve. We grade from the completely catastrophic outcomes, the ones where the child died unnecessarily, to the absolutely amazing outcomes where people did brilliantly and got everything right. Interestingly, I think in medicine, the only ones that we ever really accept for ourselves are the amazing outcomes. But they found that we grade in a curve, and that one factor was responsible for 40 to 60% the variance of this curve, and that is rudeness, how we treat each other in that situation. And that's been replicated in various ways by, admittedly, studies by them, but it was the first bit of really good, solid evidence that we had that behaviour really matters in the healthcare setting, certainly from an RCT. And normally I leave it there, but I'd like to talk for a moment or two about a different study. And this study was done by a guy called Dan Katz. Dan is an anesthesiologist in New York State. And what Dan did was a study, another simulation study, with anaesthetists who were at the stage of about to become consultants, going into an operation, and in the operation, there was a massive hemorrhage. Now, in that situation, it's the anaesthetist who resuscitate the patient as the surgeon tries to stop the massive hemorrhage. And they videoed the performance of these doctors who are about to become consultant level. They videoed their performance, and then they had blinded assessors looking at the videos later. And what did they find? Well, I didn't mention what the variable is. They either had a polite surgeon or a rude surgeon. It wasn't a screamingly rude surgeon. It was just a sort of surgeon who opened the door into the anaesthetic room going, come on, come on, come on, hurry up, you guys, get yourselves through here. And they then went and they had a look at the results. And they found that anaesthetists who had the polite surgeon were performing at just over 91% of them were performing at the level expected. When they looked at the performance of people with who had the rude surgeon, that was just under 64%. That has a p-value of 0.007, which I think we'll agree is significant. But that's not the most interesting thing about the study for me. And by the way, I don't think this study in any way is about surgeons and anaesthetists. I think it's about all of us, particularly in healthcare. What was really interesting to me about this study is that afterwards they asked the anaesthetist, did you have the rude surgeon or the polite surgeon? And they knew. They knew if they had the rude surgeon or the polite surgeon. And the follow-on question was this, so did that have an impact on your performance? And their response was, no, of course not. I'm a professional. And I think that that shows that we are not great at assessing our ability to cope with negative behaviours. So what I think the evidence is taking us towards is how we behave towards each other is the single biggest factor determining how well competent teams perform, if they have the right tools for the job. So rudeness or incivility. If it's such a big deal, how come I went to Edinburgh Medical School in the 1980s and nobody ever spoke about it? In fact, I would argue that Edinburgh Medical School in the 1980s was like a dirty, great incivility factory. We manufactured rudeness on industrial scales, and then we chose to basically export it to anywhere that would have it. And we weren't alone. But then I did my membership in surgery and in emergency medicine, and nobody ever spoke about how we treat each other in the workplace. And then I did my fellowship, and nobody mentioned it. And the reason for that is that this is new science. Between 1996 and 2001, there were 23 papers in the whole of academia about the impact of behaviour on performance. Between 2011 and 2016, there were, forgive me, there were 1,700. So, have you seen rudeness at work? How did you respond? My guess is that you felt that you were pissed off by it. But what happens in the moment is you're belittled, ashamed, humiliated, and you feel childlike and powerless. And it crushes your working memory. And how do we respond to it? We come back with hostility. There are 4 distinct groups who are impacted upon by rudeness really quickly. What happens when someone's rude to us is it squashes our working memory, it gets in the way of our creativity, and we don't perform as well as we should. And on the recipient, when somebody is rude to you, on average, that gives you a 61% reduction in your cognitive ability. And this is the reason why, in the moment, you don't have that smart comeback. Then the day finishes, you get in the car, you're driving home, you stop at the lights, and you have that moment, you go, boom, if I said that right there, right then, I would have shown them exactly what the right thing to do was. What about onlookers? You wouldn't imagine it would have much of an impact upon onlookers, but it turns out that when people are around rudeness, not directed towards them, on average, they have a 20% reduction in performance. And there's more than that. If they then get up and walk around the corner and somebody asks them for help, they're 50% less likely to help the people around the corner. But there's one group of people who are much more likely to be rude than anybody else, and that's bosses or people in authority. You're 3 times more likely to interrupt people when you're a boss. You're 3 times more likely to sit in a meeting using your computer for something else when you're a boss. And you're 3 times more likely to raise your voice at somebody because we're allowed to. We don't start out like that. So pull it together really quickly. This is 1959, Western General Hospital in Edinburgh. The NHS is 11 years old, and that's my mum. And on my mum's right is Julie, on her left is Charlotte. Julie died a couple of weeks ago. And as part of my mum's job, twice a day she has to go around and clean the ashtrays because every patient has one in their bedside cabinet. And then we learned about the terrible toll that tobacco takes on patients and society in general. And what did we do? We changed. So now it's 2020. We're beginning to understand the impact that behaviour has on performance. And that's great. What a wonderful opportunity. Because by choosing to behave in ways which value and respect the people around us, we help them as individuals to perform at their peak. When we help the individuals to perform at their peak, we have more chance of our teams performing at their peak in complex situations. And that gives us the best results for patients, but also for staff. Or in other words, civility saves lives. Thank you very much.
And thank you, Chris. That was a great talk. Can you hear me okay?
Yes, fine.
So I'm going to ask 2 questions. The first one's from Mike Weeble. What do you view as the biggest thing an organisation can do to encourage civility in all staff interactions? So
that's a really interesting question. I don't think it's something that organisations can do because I don't think many organisations model civility. So I think our organisation telling us to behave nicely towards each other probably doesn't cut the mustard with most of us when many of us see very negative behaviours from executives and from people who are meant to model the organisational behaviours. I do think that as professionals in our professional guilds, understanding that behaviour really matters starts to give us the opportunity to think about our behaviour and then to let people let us know if they have found our behaviour difficult. So organisations like SAM, the RCP, RChem, organisations like these talking about what it means to be a professional and what it means to interact in professional fashion feels to me like a better place to come at this from, rather than organisations telling us to behave in a certain way. But that might just represent my jaded view of organisations. Worked in a few though.
I'll ask one more question before we move on. So how would you advise to address incivility as a junior within the hierarchy of medicine? And we've given an example of consultants to SPRs to juniors, etc. Addressing that incivility.
I would start off by saying that, and I know this is really hard to believe, that most people who are being rude don't know that they're being rude. Now, I know how hard that is to believe, but there's a ton of evidence on this. They're behaving in a way that's become normalized, so they just think it's a normal professional interaction. It's totally unreasonable to expect a junior member of staff to challenge a senior member of staff on behaviour. It's almost impossible. It's a Sisyphean task, and the evidence on this is that people just don't do it. So you need a different kind of system. You need a system where you have somebody who speaks to the person who has supposedly been rude, and you need a second messenger system. You need a trusted, professional, confidential second messenger system where somebody comes and has, if I'm rude to somebody, somebody will come and have a conversation with me, but not the person that I was rude to. It's not fair to expect them to do that. And there are a number of different systems out there. If you're interested in that kind of stuff, Jerry Hickson in Nashville has done amazing work on this. And we've done some work with the Royal College of Surgeons of Ireland, with Hadass Levy there, and we have a thing called Calling It Out with Compassion, which is Creative Commons, and I'm not selling anything here, I'm just saying there's systems out there that we can use, but there really isn't time to get into, but there's second messenger caring systems.
Okay. Thank you, Chris. There's a few more questions in the question and answer bit. If you'd be able to answer them during the break, that'd be great.
Okay.
And thank you for that talk. That was great. I could listen to that all night. We'll move on now to our abstracts. And the first abstract up is Oliver Sharp. And Oliver's a clinical fellow in intensive care medicine at the Royal Devon and Exeter Hospital. So I'll hand over to Oliver.
Oh, hello.
Hi, Oliver.
Sorry, I think I'm having some technical difficulties. Bear with me 1 second. It's Cornish internet.
We can hear you okay if you want to do your talk.
Okay. I'll just have one more go at starting the video, and if that doesn't work, then I'll just... my webcam has decided it doesn't want to play ball. Do I have control?
If you ask, we can move the slides across, Oliver, for you.
Okay, fine. I think... sorry, I'm having technical difficulties still.
Okay, so wonders of the internet.
Yeah, here we go. Sorry about that. Hello, my name is Ollie Sharp, and until 2 weeks ago, I was an F2 doctor working in the Royal Devon and Exeter Hospital. For the next 7 minutes or so, I'm going to talk about a new triage system that we developed based on some work done in the Glasgow Royal Infirmary Emergency Department, specifically for use in our medical admissions unit in Exeter. So the Royal Dublin Exeter AMU is perhaps slightly unusual in that 55% of our patients are coming via direct admission from general practice. And for that reason, our nurses need to be very familiar with the process of triage. Previously, we were using a version of the Manchester triage system, but we found that the majority of our patients tended to occupy the middle triage category. So about 40% of our patients were coming through as triage category 3. And we were finding this was making it very difficult to prioritize patients for clerking, but also to allocate nursing resources and for frequency of observations. We weren't the first people to find this. So the team in the Glasgow Royal Infirmary Emergency Department have done quite a lot of work around triage and admission. And they found the same thing, and they developed two pathways and two scoring systems to look at this. So there's links at the bottom of the screen as to the Glasgow triage system and the Glasgow admission prediction score. At the same time, we were looking to expand our same-day emergency care services, and we found that we had no way of reliably identifying which were the correct patients to go to same-day emergency care. We didn't want to fall into the trap of just sending all of our category 4 patients to the SDEC, because we have a lot of frail elderly people who clearly require admission. And similarly, we were seeing a number of category 2 patients who might traditionally be considered the high acuity, automatically requiring admission, who we were able to turn around quite quickly. And some obvious examples of that we've seen are patients with SVTs and fast AF, who we've been able to regressively rate control and turn around the same day. And for this reason, we combined the gaps in the Glasgow triage scores and then altered them slightly to create a bespoke solution for us to use in our acute medical unit. So here is our triage tool. It may look similar to the tools you're using in your own departments if you're using one. And we asked the question, does the patient require resuscitation? At which point, hopefully, they've not reached us in the acute medical unit, but have rather been seen in the resuscitation basin in the emergency departments. And then we ask, are they septic? And if so, we perform sepsis 6, and then ask if they have any of the mandatory category 2 or category 3 presentations. From that point, if the answer to all of those questions is no, we work out their early warning score, and this calculates their triage category. Where we differ slightly from what other places are doing is after this, we are then calculating the GAPS score, which uses their triage score to calculate how likely they are to be able to be seen in same-day emergency care services. And what you'll notice here, with the exception of category 1 patients, we're not precluding anybody from going to same-day emergency care services. So even if you are a category 2 patient, you may still be suitable to be seen in the SDEC. In terms of the data we collected, in September 2019, myself and one of my colleagues requested 250 sets of medical notes and got about half of those and upset quite a lot of the admin staff in the acute medical unit when we filled up all of their shelves with buff notes. We then went through those notes using their observations charts and clerking performers and worked out, in an ideal world where we perfectly implemented this new triage system, what their predicted scores would be. We then went back through our computer system and pulled off their Manchester triage scores from their admissions. Then in December 2019, we implemented the new triage system that you've just seen. And in January, we performed a re-audit of the data. We had planned in March to go back and have a look at the data again once it become properly embedded. But then, obviously, with everything that's been happening with coronavirus, it's changed our patient take significantly. So this is our first set of data. In the light green, you can see our original data using the Manchester triage score. And then in orange, you can see our retrospective analysis of what we predicted our scores for each triage category would be. Just of note is that we had no category 5 patients because our computer system currently doesn't allow us to input category 5 as a triage score. And what this data shows is that, as we thought, the majority of our patients are, or the highest triage category rather, is category 3, that really tricky to manage, not so sick that they need to be seen immediately, maybe not be able to wait for 4+ hours to be seen. we are then seeing about a quarter of our patients in triage category 2 and another 40% of our patients in triage category 4. But we have much more certainty that those patients are seen in a timely fashion. When we reaudited the data, after 1 month in our busiest time of the year with relatively small amounts of training using our new triage system, we found that we made a significant improvement towards our predicted data. So we'd reduced our number of category 2 and category 3 patients by 5% each, and therefore increased our number of category 4 patients by 10%. The other effect that we noticed was on our same-day emergency care admissions. So in September, around 15% of our patients were being seen in same-day emergency care. And in January 2020, this had increased to 27.4%. And we're discharging about 89% of these patients from same-day emergency care back to the community. This graph shows proportions of each of the patient populations and whether they went to the same-day emergency care services across the entire medical take. And you can see here that all of the triage categories have some patients in them. So category 2, category 3, and category 4 patients are all going to same-day emergency care services, although more category 4 patients go than category 2 patients. So in conclusion, for us, we found that we've been able to take this ED-focused triage system developed in Glasgow, which is a bit of a different place to Exeter, and we've been able to make it work in our acute medical unit. As well as that, we've shown it enables us to prioritise patients better than the Manchester Triage score, and that's both in vitro with our retrospective analysis and in real life. And we've shown after just 1 month of adoption in our busiest time of year, we've significantly been able to reduce the number of category 2 and 3 patients. And as well as that, our attendance rate for same-day emergency care services is increased using this new triage system. In terms of implications for acute medicine in the UK, I believe that we've shown that by making small changes to existing triage systems, we are able to help focus nursing and medical staff towards the sickest patients in the acute medical unit, prioritising patients for clerking, allowing us to decide who gets the OBS most frequently. And I feel that that has implications for patient safety across the whole MDT. I also feel that by developing bespoke triage solutions, we've been able to identify what would traditionally be considered high acuity, definitely need admission patients, and been able to turn them around from same-day emergency care services back to the community. And by being able to do this, our triage system has allowed us to keep patients out of the acute medical unit and could potentially help reduce bed pressures and overcrowding. Oh, thank you very much. Does anyone have any questions?
That's great. Thank you, Oliver, for that. That's quite an interesting abstract.
Apologies about the camera. I still can't get it to work.
You're all right. We could hear you clearly. It was good. It was good sound. Other than Glasgow and yourselves, are you aware of anyone else that's using the GAP score?
I am not aware of anyone else who's using it personally. I know some of the team in Exeter who developed the score initially have looked into it, but I would have to ask them.
Okay. And the question just from Nick at the bottom. So it looks like you did up your admission rate to the SDAG, but did your admissions from SDAG to the ward that increase or change?
I believe it stayed fairly static. So we were still the 89% of data, or the 89% of patients discharged from SDEC was from our January data, which is pretty much in line with sort of recommendations nationally, and hadn't changed very much from our data in September.
Great, brilliant. Thank you, Oliver, for that. We'll move on to our next abstract then. Our next abstract is from Dominic Sykes, and Dominic Sykes is an academic FY2 from Hull University. I'll pass it on to Dominic then.
Lovely, thank you very much, Damon. Good evening, everybody. I'm Dominic. I'm FY2, currently working in the respiratory research group in Hull. Today I'm going to talk. Today I'm going to talk a little bit about the Hull Acute Asthma Project, a project that we developed in the Hull University Teaching Hospitals Trust to improve the care of asthmatic patients through the use of quality indicators as decreed by the British Thoracic Society and the Royal College of Emergency Medicine as well. So first of all, a little bit about asthma. As we know, it's a very common problem in the UK, with about 5.4 million people having a diagnosis of asthma in the UK. And in 2016-17, there were about 70,000 admissions to hospital attributable to acute asthma. The inspiration for this project was largely born out of the National Review for Asthma Deaths in 2014, which concluded what the sentiment of many people across the country believe is that nobody should really die of an acute asthma attack in this day and age. The NRAD found that 195 people died completely 100% attributable to acute asthma. It also found that 21% of these patients had previously been admitted with asthma in the last year. 12% had multiple attendances, and quite strikingly, 10% died within 28 days of discharge after receiving asthma treatment. The BTS then introduced recommendations in what they called an asthma care bundle to improve the acute treatment and follow-up. So this, this care bundle included various quality indicators of care, including an inhaler technique assessment, a full medication review, a written asthma action plan, and most importantly to our study was a follow-up within 2 working days with a specialist. I also mentioned the Royal College of Emergency Medicine standards. We thought we'd also review this in our study. Quite important points we believe are how acute asthma is managed in the emergency department. So in the 2017 guidance from the RCEM, some of the most important points were therapy delivered to all patients to maintain saturations of 94 to 98% if it's required. High dose beta agonist bronchodilators. Patients with acute asthma diagnosis should be discharged with prednisolone where indicated as well, and they should also receive written discharge advice. So the way we sort of conducted our study is that we split it up into 3 sort of distinct phases. The first phase was a retrospective audit of acute asthma care by collecting data from the aforementioned quality indicators from both the BTS and the RCEM. So we collected the data for that, and then we moved on to the second phase, which is the design and implementation of a nurse-led rapid asthma clinic. So what we decided to do with this was implement an electronic referral system using our Lorenzo IT system that's used in the trust, into which any patient who presented to the emergency department diagnosed with acute asthma would automatically be booked in within 2 days to a nurse-led, consultant-supported asthma clinic, so we could better satisfy those quality indicators set out by the BTS. We also delivered a couple of education sessions to help with junior doctors in the department, in the emergency department and the acute medical department regarding acute asthma care, so we could better meet the standards set by the RCEM. And then obviously we moved on to phase 3 to evaluate the impact of our intervention through a repeat audit a couple of months later after this was introduced. So the Rapid Access Asthma Clinic was, as I said, a nurse-led clinic with consultant support. Patients were all reviewed within 2 days of discharge. They had to be, in our case, discharged from the emergency department. However, I think it may also be sensible if we set this up for the acute medical unit, it would also be very have a high utility there as well, because a high proportion of patients get discharged from the acute medical unit as well as the emergency department. As I said before, they were referred using our acute respiratory assessment service team, our ARAS nurses as we call them, who see all the asthma and the COPD patients in the trust as well. And they were referred to the clinic using our Lorenzo IT system. Sorry. Oh. So the results, I hope you can see this here. I'm not sure if it was the best table I've ever drawn in my entire life. our results from our phase 1 sort of retrospective audit showed that with the RCM guidelines and quality indicators, we were meeting a couple of them, in particular the bronchodilators and prednisolone prescription. We were pretty much bang on already. We were doing quite well. We're a little bit subpar with our oxygen therapy to maintain saturations of 94 to 98%. And quite blaringly obvious, we were very poor at the BTS asthma care bundle and completing the quality indicators that the BTS has set for, including inhaler technique, GP or clinic follow-up within 2 days, and personal asthma action plan guidance with a patient. So in our phase 3 retrospective audit, after the implementation of the clinics and the education in the emergency department and acute medical units, we found that all of our indicators improved apart from our prednisolone prescription, which I think may just be an anomaly, I hope. And we've improved on the oxygen therapy, but still left a little bit of room for improvement there with only 92% post-intervention. But encouragingly, our main intervention, which was the introduction of the nurse-led rapid asthma clinic, did show that the adherence to the BTS quality indicators and meeting their guidelines, we hit almost 100% on all of our targets there, which was quite satisfactory. So in terms of conclusions that we can draw from this, we believe that electronic alerts that create automated referrals is probably one of the best ways to get around the logistical issues that can arise from trying to set up a clinic within 2 days. Luckily, we had the IT staff that were able to automatically fill the spaces that our nurses had available in their clinic just through the acute asthma admissions that were coming through the emergency department. We believe that from patient feedback and obviously the evidence-based nature of the BTS guidelines that nurse-led rapid asthma clinic will improve patient outcomes, at least in the short term, and prevent frequent readmission or bouncing back of patients from the emergency department. However, we're not entirely sure of the long-term effects of our intervention and how that will hold up in patients' long-term asthma care. Obviously, we hope it will improve their asthma control in the long term, particularly with their recognition of trigger factors and their asthma action plan to help better manage their asthma. But no, thank you very much for listening.
Thank you for that, Dominic. So yes, asthma is a thing that we see all too often, especially coming into the winter times and summer times with the hay fever. A lot of units do see a lot of recurrent attenders, especially into the resus departments of A&E. Have you noticed with your changes whether the number of recurrent attendances have decreased, or is it something that you're planning on looking at?
So yes, obviously, thank you. Yeah, so we are looking at trying to look at the patients that we've analysed from this data set and sort of look at their follow-up and how many times they bounce back or reattended. Anecdotally, what I can understand from both our specialist respiratory nurses and a few of the registrars working in the department is that the people who were bouncing back frequently, we were seeing them, on a weekly basis, or, maybe a little bit exaggerated, but they are reducing now because just of simple interventions such as inhaler technique and asthma action plan, it can really make a difference in terms of stopping those readmissions, like I say, every so often to resus departments or into the acute medical unit.
That's great. So yes, Dominic, there's a few other questions in the question and answer bit. If during the break you'd be able to type your answers to them, that'd be great. And we're going to move on to now comfort break, and thanks for that abstract. So we're going to take a 5-minute comfort break before we listen to Peter's lecture. Hello everyone again, and welcome back to the second half of Sam's webinar. Thank you to all the speakers from the first one. And we'll move on to Peter Ing's talk. Peter's from the Royal Liverpool Hospital. So I'll hand it over to Peter. thank you for presenting tonight.
Thank you very much for inviting me to talk. I'd like to start off by just telling a story from my registrar days. This wasn't actually too long ago, and I remember the details quite clearly. So when I was on call for intensive care, it was a sunny Saturday morning. I was having a ward round with the consultant and a core medical trainee. A patient had spiked the temperature, and it was around about the time when a central line needed replacing. She had a neckline in, so it was decided that we'd do a thermal approach. The core medical trainee wasn't signed off to do central lines, and so the opportunity was taken to teach a core medical trainee how to put in central line. So I broke down all the steps, explained Evan as I went along, and Evan was going absolutely fine until I came to flush the lines. The ports, and they all flushed except the distal port. And I tried all the different usual maneuvers. I pulled it back, advanced it, flipped 180 degrees, but still it didn't seem to work. Asked for advice from the consultant who then came in. She also tried manipulating the line, but again, nothing seems to have happened. Nothing seemed to have worked. However, all the other ports flushed. And so the line was sutured in place and was used over the weekend. Routine examination on Monday found that the patient had a loud, obvious pansystolic murmur heard all over the precordium. And so an echo was ordered. It wasn't until towards the end of my shift that day when one of my acute medical registrar colleagues came up to the unit to do a focused echocardiogram purely for her logbook. And this is what she found. So for those who are unfamiliar with echo and ultrasound, this black tubular-like structure is the inferior vena cava draining into the beating right atrium there. And you can see a hyperechoic linear structure within the IVC. The chest x-ray confirmed my fear. I'd left a guide wire in situ, going from the patient's IVC through the right atrium and up the SVC. Dawned on me then I'd caused a never event. So this is what I'm going to be briefly talking about for the rest of this talk. So I'm going to be talking about the processes, about what happens when a never event occurs. I'm going to probably skip over duty of candor for the interest of time, but I'm happy to take questions on that at the end. Talk about human factors and how this can lead to mistakes in healthcare. And then I'm going to introduce the concept of NATSIPs, if you haven't heard of them. And then I'll tell you the rest of the story. Sorry. So never events, these are incidents which may well compromise patient safety, and they have the potential to cause serious harm or death to the patient. And what's more is that these events are completely preventable, and they keep on recurring. And they're preventable on a national level because on a national level, there are what we call protective barriers in place to try and stop them from happening. So that might be, for example, certain equipment may not be compatible to use with other equipment, or maybe in the form of checklists, for example. And these never events are regularly reviewed on a national basis. And whenever one happens, it needs to be investigated thoroughly in a fair and open and just manner without trying to apportion blame, but to find out why these events actually occur and to prevent it from happening again. This is a table just showing the number of never events that have happened over the last year or so. And you can see month after month, they keep on happening. And there's usually a common theme with these never events, whether it's wrong site surgery or retained foreign bodies, for example. When a never event occurs, there is a framework or investigation process that needs to be undertaken. And I'm just going to break this up. So a never event may well occur up here, and then that needs to be reported to the National Reporting and Learning System, used to be called the NPSA. And that's the same body as we would report our datexes to, I believe. a decision needs to be made about whether this is a serious incident, and by definition, a never event is a serious incident. And so that also needs to be reported to the Strategic Executive Information System. And that all needs to happen within 2 working days of the never event occurring. Following that, there's a time frame of 3 working days for an initial review to be completed and submitted to the Commissioner, who will confirm the level of investigation that's required. So, for example, a level 1 investigation would be a in-house investigation that might follow from one of your bog standard DATEX reports, for example. A level 2 would be a more thorough investigation. A level 3 would be an independent inquiry. An obvious example would be what happened at mid-staffs, for example. Following that, there's then a time frame to undertake the investigation itself. And for level 1, level 2, there's 60 working days to undertake the investigation, or in the case of a level 3 investigation, a timeline of up to 6 months. And during that period, there'll be a lot of information gathering, a lot of statements written and read, and finally a report will be drawn up, and an action plan would then be submitted to the Commissioner. Once that's been received by the Commissioner will then review the report and make sure that is relevant and applicable, and the action plan seems appropriate. The Commissioner will then give feedback and potentially close the investigation and confirm the ongoing action plans for that healthcare provider, usually a trust, to ensure that this never event shouldn't happen again in the future. I said I'll probably skip over this because I think it's rather self-explanatory. I think a lot of us know what duty of candor involves, but I'm happy to take questions of that at the end if required. I'm going to move on to human factors. Human factors is all about the ergonomics of how we interact with our environments and the processes involved in everything that we do. And there's a lot of contributing factors that are involved in this. So we heard from the first talk, teams are quite important, and how you interact with your team, work well with your team, communicate well with your team can be a large part of human factors. And ensuring that the task at hand is appropriate for yourself and the team at large. Ensuring that you've got the right equipment, the equipment's appropriate, and thinking about the environments, making sure that the lighting's correct, position of the patient's correct, the noise level is optimal, for example. Culture in organisation is a big one. So some departments or organisations may well have adopted a culture of being very conscious of using things like checkboxes or checklists, to ensure to prevent mistakes from happening. There may be some departments where that culture hasn't yet been embedded within that department. Ensuring that the operator and the team have the adequate knowledge to deal with the procedure and any complications that may arise is important. And ensuring that the policies and procedures in place are relevant and applicable for what the task is. The various models used when it comes to human factors. The Shell model is a common model used in healthcare. So S stands for software, and this relates to your guidelines, protocols, and algorithms that we all use, and making sure that they are used correctly and making sure that they're appropriate for the task at hand. Hardware, H is for your hardware, which is essentially equipment, making sure that you've got the right equipment and all your equipment is compatible and easy to use. E is your environment, so thinking about things like temperature, the noise level, the lighting, the layout of the patient, and all your other equipment. L is liveware. So this is your other people involved. So this is the rest of your team, not only your team, the patient as well. Being aware about what other factors might affect your team from working effectively or efficiently. And the last L being the central library, or you, the operator, and what may affect your efficiency. There are different human factors models available. So there's the human factors integration and the systems engineering initiative as well. These are also used in healthcare, which is essentially being lifted from other industries such as the airline industry and military. So non-technical skills is also very important. And I put up HALT to remind us all to talk about HALT. And if you don't know what it stands for, hungry, angry, late, or tired, if you have any of these, or non-technical skills and technical skills, will be compromised. And we heard about some of these in the first talk, in fact. So if I'm hungry or angry, my situational awareness, for example, may well be compromised, and that can compromise patient safety. If you haven't been on a human factors course, I do highly recommend it. You come to learn that the brain is quite a powerful, interesting, magnificent organ. So you can see on a paragraph on the left there, that's full of typos or mistakes there, but if you try and read it, it's actually quite easy to read, and it's your mind just correcting all those errors and mistakes to make sense of it. And thinking about it, it's no wonder that we can overlook errors and mistakes in healthcare. The diagram on the right, you may see two faces looking at each other. You may see a vase, you might see both. Just emphasizes that we will all have different perspectives on things. So our situational awareness may well differ, not only from each other's, but also as the task progresses. So that takes me on to NATSIPs. I had no idea what NATSIPs were when this event happened. So NATSIPs are National Safety Standards for Invasive Procedures, and these are formed nationally from NHS England by a group of people made up of clinicians, professional leaders, human factors experts, and some lay representatives as well. And they're born from the analyses of never events and other serious incidents, including near misses. And essentially, they put together minimum standards in order to provide safe care for the patients during invasive procedures. And when you take NATSIPs and apply them locally in your trust, for example, they're then termed LOCSIPs, local standards, safety standards for invasive procedures. And these LOCSIPs should be audited locally to ensure that they're being used, but also they're being used appropriately and correctly. So this is one example of a NATSIP for a central line. This is taken from the Intensive Care Society. You can see it's broken down to before the procedure, timeout, and a sign out as well. So there will be an assistant or observer filling this in before, after, and during the procedure. And essentially before the procedure, they'll ensure that we've washed our hands, we've got all the correct equipment, for example. Before we actually physically start the invasive procedure, we'll stop ourselves and just ask ourselves, are we all ready? Is the position of the patient optimal? Have we got the right central line? Does anyone have any concerns? And then afterwards, we'll make sure that we're addressing certain things. So have we put on sterile dressing? Have we removed the guide wire? Do we need a chest x-ray? There's also a checklist for them to fill out during the procedure to ensure that we're maintaining sterility, whether this is an elective or emergency procedure, whether you're using ultrasound, and whether there's any complications as well. One of the biggest barriers to LOCSIPs and other protective barriers is the culture within the organisation, which I did touch upon. So this is akin to the speed limit on a 30-mile-per-hour road. So the legal limit is 30 miles per hour, but a lot of the population tends to drive just a little bit over 30 miles per hour, between 30 and 35. And that is accepted, so to speak, as the illegal norm driving limit. But I think we'll all agree that driving 50 miles per hour in that 30 mile per hour zone is unsafe and illegal, and none of us would do that. And so there needs to be a shift in culture towards the right-hand side of this graph. And that can be difficult when there are other pressures preventing this from happening. And this is one of the biggest barriers to introducing something like a LOCSIP to an organisation. So I'm going to finish with the rest of the story, but tell you what happened. So once the guide was confirmed that it was left in situ, the patient went down to interventional radiology, and she had the guide wire taken out uneventfully. Unfortunately, the patient did die, but died several weeks later, unrelated to this incident. What I went through, well, this is where never event happened, and then chaos did ensue. Obviously, patient safety was at the forefront. Patient went down to IR, but then there was a lot of meetings, a lot of essentially an investigation, which lasted for several months. Essentially, I'm now more over here, moving on, and people can take different paths. They may well change direction, and after an event like this, they may well decide that invasive procedure is not for them. They may well change their specialty or leave medicine, for example. There may be an agent of change. They may well go on to be involved in patient safety, for example. Or they may well just reflect on what's happened and continue the practice, taking on what's happened. Throughout this whole recovery process, there are intrusive reflections, more so, for me, more so at the very start, as you may or may not imagine. And it does make you question a lot of things about whether you are right for this job, whether acute medicine is the right specialty for you, whether medicine is the right thing to do, whether this is going to impact on your training, so on and so forth. And it did take a while for those intrusive reflections to diminish. And what's more, throughout all this, I obviously knew that you're not meant to keep a guide wire in when inserting a central line. I think everyone pretty much knows that. This was a really embarrassing thing for me to have done. And so restoring personal integrity was a big one for me as well to get over. This required a level 2 investigation. So for investigation, there was a team involved. These were all the members of the investigating team, which I wasn't aware of. I never met any of these, apart from the lead investigator, I think, with who I had several meetings with. They came up with a report. The contributory factors in the report shows that I was distracted from the procedure by teaching. So the responsibility of teaching just took away my concentration from the procedure itself. And I probably don't insert central lines frequently enough for it to become muscle memory for me. It's not like when I drive home from work and realize, oh, how did I actually get here? I don't remember taking that turn that I always take. I probably have to think about each step of inserting a central line as I do it. And the core medical trainee wasn't able to contribute towards patient safety. Maybe the core medical trainee didn't know that the guide wire was meant to be removed, but obviously that core medical trainee wasn't competent at doing central lines, so he couldn't participate. And there was also an assumption of competence from the consultant somewhat as well. So I was a medical registrar. However, the competencies of a medical registrar is not the same as an anaesthetist, an anaesthetic registrar. So intensive care is manned by medics and anaesthetists. Whereas an anaesthetic registrar would have done central lines hundreds of times potentially, whereas a medic would have only done it maybe a handful of times at most. The root causes of why this happened is that I did not consider a retained guide wire when I was unable to flush that line. And there's an element of inexperience that I didn't question that there wasn't a guide wire on the tray at the end of the procedure either. And teaching was a distraction and took my concentration away. Recommendations from it is that invasive procedures need whole team input, and that is quite difficult to get a whole team involved. Trainees need to have learning needs identified at the start of the placement, and consultants need to understand the training background of the trainees in order to delegate care appropriately to their trainees. And training should be observed doing invasive procedures and critique, but that's essentially what adopts the directly observed procedural skills is all about. What I was involved in, I made up various safety posters which went around throughout the whole trust. It was on the back of toilet doors to the trust bulletin, which went to everyone's email inbox. I took the NATSIP and made a LOCSIP for the trust, and also rewrote the standard operating procedure for central line insertion, which went out trust-wide as well. In terms of my portfolio, I redops myself, and I redops myself again and again. I've done it several times with several different consultants. And I reflected on everything that had happened and various aspects of the investigation I reflected on. Had lots of different meetings with lots of different people, including the investigating team, clinical supervisor, educational supervisor, discussed it at my PYA. It came up a lot of times. I had to declare it on my Form R as well. And then I was offered support. So if there were two things that made this bearable, one thing is that the family didn't pursue a complaint or anything. And I think that would have been hard on me if they had. And the second thing is that the trust was actually very good. Or the investigating team, I felt, were very good. I didn't feel like they were trying to blame me for what had happened, even though at the time I was blaming myself a lot. And they did offer me things like counselling, which fortunately I didn't feel like I needed at the time. So I think I'm just going to leave it there, and I'm happy to take any questions. Thank you.
Thank you for that, Peter. That can't have been an easy thing to have talked about. And knowing you personally and knowing how great a trainee you were and how great consultant you're going to be, it makes it all the more that mistakes do happen and can happen to anybody. And certain models being in place to help prevent these mistakes is probably the way forward and the way things need to be done. It's interesting you mentioned the family at the end there. Who told the family of the mistake, or told the patient of the mistake? Was that left up to yourself, or was that left up to somebody else to do?
Yeah, so I remember when I saw that echo image in the chest x-ray, my heart sank. Essentially, it felt like a fish hook in my heart and just pulling it down into my pelvis. There was a overwhelming feeling of nausea. But there was also a sense of, I need to take a bit of responsibility here. I offered to speak to the family myself. Bear in mind, this was at the end of my shift. We were just having handover, essentially, when this came to light. And the consultant in charge said they would do it, essentially. And I was quite relieved, to be quite honest, because I think if I'd spoken to the family at the time, I probably wouldn't have been in the best state of mind. And I probably would have cried. No doubt about it. I did offer to speak to the family at a later point if they wished, which never came about.
Another question from Dan. When and how were you involved in the process as an individual at the sharp end? And how do you think individuals who might be in your situation should be involved in the investigative process? So at the end.
Sorry, say that again, sorry.
So how do you think individuals who would have been in your situation should be involved in the investigating process? So it should,
yeah, thank you for that. I think you will be involved in the investigating process if you're involved in this, in something as big as this. So you will have to have meetings, and you'll have to write a statement and reflect on everything that has happened. I think this was a great learning process, and speaking to my supervisors at the time, it was a learning process for them as well, because obviously we don't always see nev events up close and personal. Something that we hear about and think it's never going to happen to me, but this did happen to me. And I think being part of that investigating process is actually quite valuable, and there are lots of learning opportunities from this, and that's part of the reason why I decided to talk about this. So I think being involved in one respect, you don't really have much of a choice, but it's also a great learning opportunity, and it does make you appreciate how the mistake came to light and how it happened.
Brilliant, thank you. And it's an important thing as well, you mentioned at the start about day taxes, and it's something that we can do locally and ourselves, and it's something to remember that it's not always there to cause blame, but it's there to learn from things that have gone wrong and how to improve that and prevent or to improve patient safety.
Absolutely, and I think it's a national reporting and learning system, and that's what it is. It's a learning system, and that's how we come about to develop these protective barriers, so to speak, to try and prevent these errors from happening.
Brilliant. Thank you, Peter, for that, and thank you for taking the time to teach us about that.
Thank you.
There's a few questions in the question and answer bit. If you'd be able to answer them, would be great. And there's also on the chat, there's quite a lot of mention of you on the chat as well, if you want to have a read through that, which is by Victoria Cornell. And Victoria is an ST5 in renal and GIM in Royal Devon and Exeter Hospital. So I'll pass you on to Victoria.
Hi, thanks Damien. Hi, I'm Vicky, and as Damien said, I'm one of the trainees at Exeter Hospital, and I've done this talk today about departmental induction, and I took part in a research project as part of my Masters in Clinical Education looking at departmental induction, and I wanted to present that information to yourselves today. So why is departmental induction important? Well, we've known for over 20 years that departmental induction is really variable, and that's not just in its existence, but it's also in terms of its content and its effectiveness. And research more recently, perhaps more in the FY1 doctors and in their starting in jobs coming from a medical student background, has shown us that a good induction can really increase their competence and reduce their anxiety around becoming doctors. And it also can have a really important impact on improving patient safety. And some research has linked a good induction to reducing that 4 to 12% increase in mortality that's quoted around August time when new junior doctors start as FY1s, but also when the other junior doctors are rotating around departments. And based on all this evidence, in 2012, we know that NHS England mandated that all first-year junior doctors have a 4-day induction. And while we know that that's probably improved things, it certainly hasn't completely resolved the issue of how can we deliver departmental induction well. The GMC also looked at the induction research and evidence, and they also said for all junior doctors, not just those who are first years, that an effective induction is a crucial welcome to the doctors into a department, and it helps them to have a real positive impact on your department as well. So this research, we wanted to try and understand what the junior doctors felt about departmental induction. And the aim of this research was to get a feeling from the junior doctors about whether they felt induction was being done well, whether it was not being done well, and try and identify the really good aspects and the really poor aspects and trying to improve the situation with departmental induction for junior trainees. And this study looked at core medical trainees, so those who'd had 3 or 4 years experience of 4 monthly rotations, so a really large experience of departmental induction from a personal point of view, and also being that bit further on in their training. And to try and understand their thoughts and feelings and what they thought could be done with departmental induction to improve the situation, semi-structured interviews were used. And that was really because departmental induction is something that can be quite difficult to understand. It has a lot of human factors feeding into it, but also a lot of processes and system issues. And to try and understand something this complex, and it obviously is complex because this evidence suggests we're still not doing it particularly well, semi-structured interviews seemed a right way forward. We then had transcripts of lots of interviews, and it was really working out how to analyse that and get the most out of our data. And the decision was made to use a thematic analysis. Now, I thought I'd just have a bit of a chat with yourselves about how thematic analysis can be used and why we used it here. So with qualitative data and particularly interview transcripts, it can be quite difficult to make the results into a structured format. And by using thematic analysis, going through the interview transcripts recurrently, trying to pick out those common comments and those common themes from all of the participants' interviews, using a thematic framework like that on the right, which is what this study used, it helped us identify recurrent themes and gave us a structure to our results and helped us to try and draw meaningful conclusions from quite a complex and heavy qualitative data set. And I'm going to run through some of those now. So some of the key points I wanted to try and get through in the 7 minutes today was the existence of induction. And the research from this project suggests that induction is still extremely variable. Some of the quotes here say induction is sometimes done, sometimes they're doing it well, sometimes they're not even trying, and that's for all sorts of reasons. And I think that supports a lot of the research out there already around induction. Another trainee said it can be pretty patchy and that they've never found one that they thought particularly useful. And I think that again gives us a lot of ammunition that we should try and improve things for the juniors trainees. Another aspect of the existence of induction I thought was important to address today was the opportunity that we often have with missed induction. So we know a few weeks ago when everybody changed over at the beginning of August that junior doctor staffing can be really thin on the ground, and often juniors are starting on nights or are in trust induction, and often those who are already present are stretched across departments. And induction often happens in that first 1 or 2 days on a job, and if they're not there for that for whatever reason, then it's often missed. And these quotes support that really nicely. The participant for that first quote saying sometimes somebody might be post nights and induction is never repeated and it's lost and gone. Another junior doctor pointed out their bleep went off 5 minutes into it, patients get sick all the time. And by the time they came back, nobody offered to read or summarise. And again, that was a missed opportunity to induct the doctor into the department. Another aspect of induction I wanted to talk to you about today was the impact of the experience. And some of the key themes that came out through this research was a good induction could have a really positive impact on welcoming and valuing, making a junior doctor feel welcomed and valued into a department. The first quote says about, again, valuing somebody, and that it might sound silly, but they didn't want to just feel like another cog in the CMT rota. The second quote feeds quite nicely into what Chris Turner was saying earlier about civility. This participant was saying they've done jobs where 3 or 4 weeks in, no one said hello, consultants haven't introduced themselves, and they felt pretty pointless. And I think we'd all agree we don't want our junior doctors feeling pointless and feeling not welcomed or valued. Another aspect of the impact of the departmental induction experience is that feeling of frustration, and you could really feel that in this research. Particularly the doctors are CMTs, they've been training for several years, they're driven juniors who are interested in medicine, and I was talking to them when they were on medical rotations, and this feeling of frustration of not knowing the basics, where to put their bag, no one showed them where the toilets were, and that's really illustrated in that first quote. The second quote was saying about feeling frustrated, they go home later on those first few days of rotation because they want to make sure they're doing a good job and they don't know the processes very well. Another participant, not on this slide, was saying they didn't want to sit at the ward clerk's computer, they didn't want to upset the ward clerk on the first few days, and I certainly remember that feeling. So what does this research tell us, and what does it add to what already is out there? So departmental induction remains really variable. We've known it's variable for 20 years, and this research suggests that's still the case. And the feeling of frustration and feeling unvalued were really key findings. That really rang home with me that we're not getting this right. If junior doctors are feeling unvalued, then that's a really bad place to be. And better consistent inductions needed to support and retain junior doctors going forwards. So what can we do with this research, and what can we feed back to our own trusts and departments? So they can look at, I think it's important we all take back to our own trusts, have a look at our own induction programs. Is there anything we can be doing to make trainees feel welcomed and valued? Ask your juniors in your department and emphasize the importance to those who run the inductions in your department. And based on this research and the evidence that we already have, what could a good induction look like? On the first day, make sure somebody senior welcomes those trainees onto the ward, gives them an idea of what the day might look like, and introduce them to the key people, perhaps the matron on the ward. and tell them when in the next couple of days you're going to be able to sit down with them, maybe over coffee, and give them a bit more information about the practicalities of day-to-day work. When will they get, how can they request their annual leave, their supervisors, how can they get involved in the department? Don't leave it till 5 p.m. on an evening, which one of the participants in my group said happened when they were told about exception reporting after 5 p.m, which the irony of that wasn't lost on them at the time. Try and get them, the MDT, involved in teaching. A lot of the juniors said they really appreciated when a specialist nurse took time out to teach them, particularly if it's a diabetes specialist nurse, or for me, a particular area of dialysis that a specialist nurse is really, really expert in. They're really good people to teach them, and they're really keen to have that teaching as part of their first month in the job. Catch up with the juniors halfway through the rotation. Is there anything they need more supportive wise? Are there things that need to be changed in those first few weeks to support them better? And get feedback from the juniors at the end point and act on it, change things if we can. Too often induction booklets particularly are 20 years old, and the FY1 who is in the induction booklet is now a consultant in the same department, and if we can't be bothered to update it, then the juniors are not going to want to read it. And if you look through those last 5 points, I suppose, on the slide, they're simple, they're easy, and they're low cost things, and they can have a really big impact on the junior doctors and on your own department if their junior doctors are inducted well. Thank you.
Thank you, Victoria, for that. So obviously, as a trainee, I've just moved to a new hospital and then had induction. With COVID, I know a lot of people are having virtual or distanced inductions. Do you feel that that's a benefit or a hindrance to their induction to a hospital or a ward?
I think we're all having to adapt, aren't we, to a slightly different way of life, MS Teams and Zoom. And yes, you lose that face-to-face, which I think is important for junior doctors. However, as long as the content is still being delivered and you can still welcome them and value them, even online, and actually if that gives them more resources and more makes them feel more comfortable starting a job, then I can't see that as a negative.
And another question is about ACPs or PAs, them being on the wards. Does that help with induction of junior doctors coming on to the wards? And I'll let you answer that question first. And then.
So yes, so at the moment in my department, we've got a trainee ACP, and obviously they're a constant on the ward. And although ACPs weren't something I think that were perhaps in when we did this research, a lot of the junior doctors were saying if there was a trust grade doctor who was staying within the department, or maybe a GP trainee who was on a 6-month rather than a 4-month rotation, if there was somebody in the department at a junior level who was there day to day, who could be involved in the induction, they felt that was a real benefit. And I think that's a role that the PAs and ACPs coming through now can play a really vital role in this, because they're there day to day and they can really help the juniors settle in.
Great. But Griffith, if you could answer some of the questions, there is more about ACPs and PAs there as well. And thank you, Victoria, for your talk tonight. I'd like to thank all the speakers tonight. It's been a great number of talks, and quite a lot of interesting things as well have come up. So we'll move on to, we've got a few polls first of all. If we can bring up the polls. So the first poll is, please rate your understanding now of civility saves lives, from the first talk from Chris. Let's see the results of that. Okay, so a lot of more people are going for high now, that's great. We'll move on to the next question. Please rate your understanding now of, I'll not try to pronounce that and embarrass myself, but first do no harm, and that's from Peter's talk. Have a look at the results of that. And quite a lot of number higher now, which is a lot different from the first at the start. Move on to the last question then. So if you were to add in another system to help with interactivity during the webinars, such as Mentimeter or Vvox. This is via a second device such as a mobile phone. Would this be easy for you to use if you've used it before? Just a yes, no answer. Look at the results. And quite a lot of people said yes, which is interesting. Oh, that's good. Thank you everyone for answering that. So our next webinar is on the 29th of September, and we've got some more great speakers then, and that will be at 7 o'clock to 9 o'clock as well. You can register as before on the website. Move on to the next slide. And also to mention, all the resources from all these talks will be on SAM's website as well. We also have coming up is our, if anyone's doing exams for the trainees, or if anyone just wants some learning, during September, we'll be running 4 sessions on a Wednesday evening for the SCE revision course. This will be run from 6:30 to 9:15, and it starts on the 2nd of September. And this looks quite great as well. You can register for this on the address on the screen, or email samconference@advantage.co.uk. Thank you for everyone to attend tonight, and we look forward to seeing you at the next webinar.